How about our laundry list? Do we have anything that we want to add to our laundry list? Either from week 1 or 2 that was confusing or this past week that stuck out? Okay, we'll go ahead and dive right in then. So this week we transition into hospitalization. So this week and next week, we're going to talk about the hospital process and how that relates to our pediatric patients. So the first thing we have to do is get permission to treat you. So we have two different levels of consent. We have a general hospital consent that covers our everyday, and then we have certain situations that require informed consent, that extra level of consent. So, which of those situations that you see would require that higher level of consent? You guys can vote on these. There we go. Okay, so our general hospital consent is going to cover those everyday run of the mill kind of standard procedures that we do for all of our patients. Our extra level, that informed consent, is going to cover those increased risk procedures that are optional. So, blood transfusions, invasive procedures, so things like surgeries, those require that extra level of consent because we do have that added risk. So we're going to explain the risks and the benefits, and then the patient actually has a choice whether or not they move forward with that particular procedure. Um, Life-threatening emergencies, we are going to wait until after we've stabilized you to go about doing any paperwork. If we make you sign some sort of a consent form before we actually provide you any care here, there's potential that you won't be alive long enough to sign that form for us. So we're going to go ahead and stabilize you and hold off on any of that paperwork until after you're able to make those decisions for yourself. So we know that our pediatric patients require some extra precautions in order to keep them safe. So what are some examples of those additional safety precautions that our pediatric patients have that our adults don't? You guys can type them in or shout them out, either one.
The like guardrails on the cribs, like, and then I forget what it's called, but like the bubble thing that goes above the crib.
Yeah, absolutely. So crib rails have to be up. And then if we're extremely agitated or we're really mobile, and we tend to be a climber, we can use that plastic bubble top to make sure that we're not climbing over those side rails.
Also, transporting them on a gurney or stretcher or anything like that. They're tinier, so they could roll around easier. So making sure that they're um, properly like strapped down or transported correctly from, say, like surgery or something, just room to room, that they're being transported correct.
Yeah, so for our infants, we're definitely not just going to lay them on a stretcher. We're going to leave them in their crib. We're going to transport them in their crib. We can use wagons. We have pediatric size wheelchairs so they don't like fall through the hole in the back or in between the armrests. Um, just making sure that we're modifying our equipment size to our patient size there. What else?
What about things that are like choking hazards around?
Mhm. Yeah, absolutely. Choking hazards just in general, because there's lots of fun things to explore in the hospital. But we also have to think about toy safety, even in the hospital. We've got toys there as well. Medication safety, infection control, emergency preparedness. Yep, those are all going to be standard for all patients. But we do have some extra caveats with our peds.
Not putting their cribs close to outlets.
Yeah, where we position them in the room. We don't want them near outlets where they can stick things in. We don't want them right next to the code blue button where they can hit that by mistake. Um, Same thing with our IV pumps. They like to push buttons. So that IV pump has tons of buttons on it. So you may need to spin it with the buttons facing away from them, or you may even have to lock your IV pump so they can't change your settings.
Not leaving any meds sitting out.
No meds, no supplies sitting out.
What about like the stabilizing their IV, like their arms because they move so much?
Yeah, so sometimes they need that extra support. With our toddlers and our preschoolers, they have that fear of bodily harm or body mutilation. So even if it's just a teeny tiny little paper cut to them, it is the end of the world. So we've got to cover those things so that they feel complete and secure. It kind of minimizes that fear that they have. Age appropriate communication for sure. Um, I think we got most of them. Anything else we can think of? Okay. So now we're going to put this into practice. We're going to look at this little scenario here, this picture, and where do you see potential safety issues?
The bed rails are down on the bed.
Side rails are down. Bed's also up in the air. What else?
It don't look like the mom is paying attention.
Yeah, nobody's paying attention to either child in the room. Both the adults have their backs to them. Anything else we see?
Is the little girl licking the wall?
It does kind of look like she's licking the wall. We really have no idea what she's doing. But she's definitely standing outside of a bathroom door. So if there's somebody in that bathroom, they could easily smack her with the door. We have no idea what she's doing over there, but she's definitely not supervised.
The little boy looks like he's trying to get off the bed.
He looks like he's dangling off that side of the bed, so he's about to jump. What if he was on continuous IV fluids or oxygen? What extra hazard does that bring into the picture?
Well, like cords laying around, tripping.
Yeah. Yep, we've got a tripping hazard. We got to make sure mom feels comfortable with moving that IV pole around with him. She's paying attention so he doesn't try and get out of bed on his own. Anything else we see in here that could be potential issue? We don't necessarily know what's in our cart there in the corner, but if it was a med cart or if it was a supply cart, we would ideally want to have that locked so that they can't go rummaging through the supplies and especially not medications. Thankfully, here we have male and female siblings, but what happens if we had twins? What could potentially go wrong?
You need to check
Patients
the
mixed
birth
up.
bands.
Yep. We got to ID them with their armbands so that we know that we have the right patient. We don't get them mixed up. When we are storing our oxygen tanks, how do we have to store them?
Upright and make sure they're secured tight.
Yep, they have to be secured to something. Ideally, we want them standing upright. Sometimes they will be attached horizontally underneath your bed, but they have to be secured to something. Why is that so important?
Because when if it like drops or something or hits hard, it can like blast off basically, and it could hit someone. It's strong, so it'll really hurt somebody.
Yes. So when those oxygen tanks fall, if they land just right on that valve, it is a missile through that room. It can go through walls and obviously cause great deal of injury to anybody in its path. Somebody in the earlier class this morning said, have you ever had one tip on your shin? Because it hurts real bad. So even just that little bit of wiggle room of just that heavy oxygen tank tipping and smacking you right on a bone is really painful. So definitely making sure that those are secured. So we're going to do a little bit of reflection here. And these can be actual experiences that you guys have had, or these can be completely hypothetical, made up situations. But think about a time that you've had a positive experience in any type of healthcare setting. What about it made that such a positive experience?
Nursing, the way they approach you and treat you, that's what makes it a good experience.
Mm-hmm. Yeah, hopefully people are welcoming and warm to you. What else?
People with children, whenever they walk in, nursing or doctors isn't only, assessing the patient, but they're also talking to their child and making sure they feel comfortable with what's going on too.
Yeah, it's really easy with pediatric patients just to come in and talk over them and talk to mom and dad because they actually understand what you're doing and they're the ones making the decision. But taking that extra time to also talk to that patient in front of you and explain things on their level and have them included in their care. What else? The cleanliness of the room. Yeah, nobody wants to walk into a dirty room and be expected to stay there. Okay, so the easier of the two questions, contrast that with a negative experience. What was different about that experience that changed your perspective?
I had a negative experience when I had my daughter. My urine got mixed up with 6 other women, and they thought that the urine that I got mixed up with had like 2 different types of drugs in the system. So they thought that I was a drug addict and completely changed the way that they were treating me. And they like put cotton balls in her diaper and like made her, it was just a really uncomfortable experience. So then when they figured out that it was a mistake, that nurse had to come in and apologize because she completely was acting like I was not a human being because she thought that I was a drug addict.
Ah, so not only did you have a lab error that was a problem in and of itself, but then the staff treated you completely differently and were 100% judgmental based on said lab error.
Right.
Yeah, that's definitely a negative experience. Anybody else?
When I had my stillborn child, I went to the bathroom and I was like 4 months along. So they induced my labor and made me have the baby. And whenever I had it, I went to the bathroom and it was already coming out. So I had screamed for the nurse. And she got so upset with me because I didn't want to walk with it in between my legs that she took the umbilical cord and literally ripped it out of me.
Oh my.
Yeah.
Oh my. Yes. Definitely not patient-centered care in any way, shape, or form. Not appropriate procedure at all. And not human. Other bad experiences that we've had.
I had a doctor come in and tell me I couldn't leave till they gave me potassium because my potassium level was low. He left. The other doctor came in and said, "You're leaving now." I said, "What about my potassium?" He said, "I don't know whose chart he looked at, but your potassium's fine." I already knew that because I checked my own labs on my chart. But yep, he wanted to give me potassium for no reason.
Yeah, mixing up patients and not checking who's in the room before you start talking to them, making sure you have that right information. Yeah, all of these are horrible experiences. Have you ever been to a doctor's appointment or been a patient in the hospital and they're standing in the doorway of your room with their arms folded, and half the time they're just checking their watch like every 5 seconds? What does that tell you about them?
That they can't wait to get out of there.
Mm-hmm. Can't wait to get out of here. I don't have time for you. I don't want to be here. Definitely, our body language says a lot about our, a lot of communication happens with our body language. So, with these positive and negative experiences in mind, how do we make sure that we create that positive, welcoming atmosphere for our pediatric patients?
Warm, friendly smile, greeting them, active playing, um, explaining everything that's going on, letting them like feel lights and stethoscopes, anything of that sort, giving them your name badge to play with, anything that helps make them feel comfortable and calm.
Yeah, absolutely. Being able to handle something that's going to be used on them takes a lot of the fear of the unknown away from it. So all that medical equipment becomes less scary when I can put my hands on it, assuming that it's safe for me to play with. What else?
Letting parents be involved in their care to show them that it's okay.
Yeah, absolutely. Parents are going to be responsible for taking care of them at home, so you might as well let them do it when they're in the hospital too. It's going to go a lot smoother that way.
Making a
Even,
place look less clinical in general.
yeah, hospitals have put a lot of money and effort into kind of taking the sterility out of hospitals, especially for our pediatric patients, making it a more inviting, roomy experience instead of medical equipment out in the open all the time. Something as simple as sitting down when you come in the room. That just immediately conveys that I am here and ready to listen. I have all the time in the world for you. So, something as simple as that can totally change the hospital experience. Okay, so let's move into our assessment skills. So, what are some of those expected findings, those normal findings in a pediatric assessment? How are they different than our adults? How do we approach them differently?
Blood pressure will be lower in pediatrics than adults.
Mm-hmm. Yep, absolutely.
You also have to do a pain assessment if they're able to talk. Pain assessment differently. You'll have to use like the faces and um, not the number scale or any other scale.
Mm-hmm. Yeah, we've got to pick the right pain scale to use. We've got a faster heart rate. We have to assess milestones.
You have to convert the weight as well.
Yeah, we got to get that weight in kilograms. Looking at their nutritional status. Yeah, we plot them on a growth chart. We don't do that with our adults. Immunizations. Yeah.
Do the most invasive vital sign last, like the temperature?
Yeah. In order to get an accurate heart rate and respiratory rate, we need to be as hands off as humanly possible. Um, even that blood pressure in an infant, you got to sneak it in there and get it when they're nice and calm. Behavioral and emotional health, using pictures can sometimes be easier to communicate. Yep, calming mechanisms, teaching them how to work through their feelings, how to soothe themselves. If we were assessing an infant, how would we approach it? Do we just come in and chuck them in a bed and pull their blankets off?
Would we have the parent hold them sometimes? If
Yeah, ideally, if you can assess an infant in parents' arms, they're going to cooperate a lot more with you. They're going to stay calmer longer. We also want to keep them nice and warm and cozy. So we're going to leave them swaddled as much as possible. We're only going to uncover what area we're looking at that time. As soon as we're done, we're going to cover it back up. That swaddling gives them that protective womb-like feel that they were used to.
I would say like having toys or other things around is like a distraction option.
Yeah, absolutely. Anything else we can think of that's different with our pediatric patients?
Would you look for signs of like abuse?
Yep. Yeah, we're going to have to be visually looking for those signs, listening to those cues. Takes a little bit more detective work with our pediatric patients because they can't always verbalize what happened. Age appropriate language. Yeah. Takes a lot longer. Okay, good job, guys. So now we're actually going to look at a patient together. So we're going to look at Eliza Simmons, and you can either follow along on our screen or you can open her up in CJ Sim and follow along there. But we're going to start by listening to the handoff report. And then if you are actually following in CJ Sim, you can skip ahead to question 3. We're actually not even going to look at the questions. We just want full access to her entire chart. And as you're listening to our handoff report, think about what is the important things that they told us and what did they leave out that would be essential for caring for Eliza. Then we're going to look at her assessments and see those normal versus abnormal signs. So let's take a peek at Eliza here. And she is 9 years old. She fell from her treehouse and fractured her femur and required surgery. So we're going to get report from the PACU nurse before she heads up to the floor.
This is the PACU nurse giving you a transfer report for a client we are bringing to your unit shortly. We should be there by 1920. Eliza Simmons is a 9-year-old who fell this morning approximately 14 feet from a treehouse in her backyard. Eliza has autism spectrum disorder. The total body scan revealed no fractures, except the right femur was a complete non-displaced and closed fracture. She has many scrapes and bruises, but no internal injuries. She did not lose consciousness, and she was cleared of C-spine. Neurologically, she is stable. It is believed she took all the weight of the fall on her right leg. She is here with her 2 dads, and they will be coming to the floor with her. The surgery included pinning of the right femur. Her estimated blood loss was 250 milliliters, and she received 1 unit of PRBC's estimated blood replacement, 200 milliliters. She has a long leg cast to the right leg from her toes to her groin that is still wet. Neurovascular status to her right foot is intact. She has an IV in her left wrist infusing D5, 45 NS at 60 milliliters per hour. She has not voided since surgery. She is sleepy and just received a dose of morphine in the PACU. Breath sounds are really shallow. We keep encouraging her to take deep breaths, but so far she is refusing. We use the FACES scale for pain, and it worked well since she is still so sleepy. For any other information, please check the EHR. Thanks so much. Call with questions.
Okay, so based on that handoff report from the PACU, what was the important things that they included?
That she was autistic.
Mm-hmm. Absolutely. She's on the autism spectrum. What else?
That she fractured her right femur.
Mm-hmm. What our actual injury was?
That she got blood.
Yeah, she got blood. Really important to know.
That she did not lose consciousness.
Yeah, that's good.
And that she received a dose of morphine in the
Mm-hmm.
package.
She's
Location of
refusing
her
taking deep breaths.
What was that,
She's
Arlene?
she's refusing taking deep breaths.
Yeah, refusing deep breaths. Brittany, I think you had something too.
location of her IV and what was given through it.
Yeah. Anything else?
Her breath sounds are shallow.
Mm-hmm. Shallow breath sounds.
The amount of blood she lost.
Yeah. Important to know. And how much they replaced as well.
Also that she has not voided since surgery.
Mm-hmm. Yeah. How about things they left out?
Vital signs.
Vital signs. Anything else?
They didn't say how much pain she said she was in.
Yeah, they didn't give us a pre-medication pain score, post-medication pain score. Didn't tell
Or
us
the time
anything.
or the time she received her morphine.
Yeah, we don't know what dose they gave, when she got it, did they reassess her pain? Anything else we'd want to know about her?
Would it be important to know whether or not she has allergies?
Yeah. Absolutely. Okay. Well, let's take a peek inside her chart and see what we find. Okay, so right off the bat, our kind of admission nursing note here. She's had no surgeries or significant medical issues. She has autism spectrum disorder, functions at a high level, can read and write. She prefers routine and order, struggles with changes in her normal day, and one parent will be at her bedside at all times. And lo and behold, Eliza has several allergies. So she's allergic to latex, peanuts, adhesive, and environmental allergies. So, what are some key things that are going to change how we care for Eliza based on just that initial nursing note?
And use latex gloves.
Yeah, we got to change our gloves. What else is important to keep in the back of our mind?
Would it be her adhesive for the IVs?
Yeah, we're going to have to be careful with adhesives that we use.
That she struggles with changes in her day to day.
Yep, she does not like change. She likes that routine and order. And right off the bat, being in the hospital is going to change that normal routine. So, how do we minimize those changes for her?
Her parents there.
Yeah, thankfully, she's going to have one parent at the bedside at all times. So, if Eliza doesn't feel like answering us or telling us how she wants it done or what her preference is, then we can utilize both of her dads to be able to give us that information. So let's look at our initial assessment when she got there. We have our right foot and left foot don't have any changes to them. We don't see any swelling. Our toes are warm and pink. We can move them. We have good pulses and cap refill, positive sensation, and our pain is a 2 out of 10 on our FACES scale. We have that long leg cast to our right leg where we had surgery that goes from our toes to our groin. It is still wet to the touch. And there is red drainage noted on the cast site, and it's marked with a felt marker. So, what are two really important things about that cast?
Is wet and is red drainage.
Yep, it's wet and there's red drainage. So, what do we have to be careful of?
Infection.
Possible infection.
Skin breakdown.
Skin breakdown. We got to make sure that we're not putting pressure points in that cast while it's still wet and pliable. Obviously, she can't be weight bearing while that cast is wet. What are we concerned of with that red drainage? We're a fresh post-op patient.
Open incision.
Yeah, absolutely. We just had surgery. We've got a big old incision there. So lo and behold, 20 minutes later, that red drainage extends outside of that marked spot on the cast. So are we just going to sit and watch that, or do you think we're going to intervene?
Intervene.
Yep, we're going to have to take action here. So we call our healthcare provider to come to the unit, and they go ahead and order a half dose of morphine to give before they arrive. So we know we're going to be manipulating that cast. So we want to make sure that we're pre-medicating her to try and keep her comfortable. So we give that half dose of morphine, and our provider comes up to the floor and ends up cutting a window into the cast. And we see that our incision is actively bleeding. So we resuture that spot, put on a liquid plastic bandage or dressing, and not shockingly, Eliza becomes agitated. She calms with soft music, repositioning, and room darkening. Just kind of updating her overall progress. She's now taking sips of diluted apple juice and water. She's able to void using that fracture bedpan. Her breath sounds are still shallow and rapid, and she's refusing her incentive spirometer. We've got both parents at the bedside. So we were right. We had some bleeding going on. So now we have a nice window cut into our cast so that we can visualize that incision that was previously covered. What else did we learn about Eliza that will help us if we have any procedures in the future? When she got agitated, what did we learn about her?
To use music, it calms her.
Yeah, she calms with music, repositioning, darkening that room. So the next time that we have to do a procedure with her, we can go ahead and implement those things ahead of time. Maybe instead of having the overhead lights on in the room, we just use a spotlight so that we can just light up that one area that we're working on. We can make sure that we turn on soft music ahead of time, making sure that we can position her in a way that she's comfortable to the best of our ability. Why is it a problem that she's not using her incentive spirometer? What is she at risk for as a post-op patient?
Pneumonia.
Pneumonia.
Yep, pneumonia. She's got shallow breath sounds. She's tachypnic. So high risk for pneumonia here. Are incentive spirometers fun when you're 9? No. They're weird looking. They're confusing. You don't really know what you're supposed to do with them. So what could we do with Eliza that gets the same deep breathing action that would be more fun? She might be more inclined to do this over an incentive spirometer.
Hey, blowing bubbles.
Blowing bubbles, yeah, that's a great one. What else?
Cough.
Blowing up balloons.
Yeah, blowing up a balloon as long as it's latex free. Working on those coughing and deep breathing things. We might be able to get her to do those. What do we do at the same time every year? Involves a cake and singing.
Candles.
Yeah, pretend we're blowing out candles on a birthday cake. Get you to take a deep breath. Uh, we can make it a game. Have her blow a cotton ball across the bedside table. See how far she can get it to roll. It could be as simple as having her shoot for a high score on that incentive spirometer. Anything that makes it a game, makes it more fun, will encourage that compliance. So she'll be more likely to do what we need her to if it's a game. So now we have our second complication that arises. So we are going to give an SBAR handoff. So we're going to start with overall snapshot of who we're talking about. So we've got a 9-year-old that had an open reduction and fixation of a right femoral fracture last evening. What's been kind of going on? Our background says our toes were swollen last night, but the swelling resolved by this morning, at which time her neurovascular assessment was within normal limits. Now our swelling has increased. So what are we seeing right now? What's our most recent assessment? Our toes are cool and pale. She cries when asked to wiggle her toes. Her pedal pulses are weak. Then we're going to give our recommendation. So we're going to tell what we've done so far and what we would like to see happen. So we've elevated her right leg on 2 pillows. I ask that you come evaluate Eliza within the next hour. So what are we concerned about with this picture? Anjanae has it. We are concerned about compartment syndrome. Yep. So that swelling, that cast is cutting off our circulation. So when we look at that neurovascular assessment, we see our left foot is totally normal, but we've got that significant swelling to our right leg, um, poor perfusion causing those toes to be cool and pale. It's painful when she moves. She has a good femoral pulse above that cast, but that pedal pulse below the cast is weak. Also, prolonged cap refill. And her pain is now an 8 out of 10. So, what do we need to be prepared to do based on that assessment?
Surgery for incision, right?
Yeah, we're going to take that cast off. So, that cast is what's cutting off our circulation. We're going to have to remove that and probably reapply it. So later on, we've kind of recovered from that second complication. Now we notice that we have significant swelling and redness with our IV site that's going up the arm. So we take out our IV and we need to decide whether or not we're going to restart it. So looking at her current status, she's taking oral fluids well, eating crackers without nausea or vomiting. Her bowel sounds are active. She's voiding sufficiently. Her pain is being managed with oral codeine and acetaminophen, and they are working on teaching with her parents. So, what are our thoughts on restarting that IV? Do we need to?
No.
Nope. We can leave it out. She's doing everything that we expect her to do post-operatively, so she is stable without that IV. For pediatric patients, we don't leave an IV in if we're not actively using it. Okay, so let's take a peek at her flow sheets and her vital signs and pain assessments. What do you see here that could potentially be concerning?
Temperature.
Yep, we have a slightly elevated temperature.
Heart rate.
Heart rate's a little high too. Anything else concerning with that picture?
Her oxygen level.
Yeah, she's on 1 liter nasal cannula and she's only at 94% oxygen. So we would expect her to ideally be 100%, but at least the high 90s with having that supplemental oxygen in place. So, what are our concerns here with those vital signs? What could be some of those diagnoses that we're worried about?
Infection with the fever.
Mm-hmm. Infection is a big one. We already talked about potential for pneumonia with those shallow respirations, low oxygenation. Okay, so let's take a peek at our orders here. So initially when we came to the floor, we had our continuous IV fluids. We had 3 different pain meds ordered. So we had IV morphine for severe pain. We had oral codeine for moderate pain, and then oral acetaminophen for mild pain that could also be combined with the codeine. We have our pre and post-op antibiotics, NPO until we wake up, then advancing through clears and advances tolerated. Bed rest for the night, out of bed to the chair tomorrow. They want her doing that incentive spirometer and they consult physical therapy. After we had that first complication with the incision bleeding, we had to increase our assessment of that area. So they want us to monitor the incision site hourly for that first 24 hours. And they also added a hemoglobin and hematocrit to labs in the morning. And they're going to keep her on bed rest just a little bit longer. Anything else that you would like to see in light of her vital signs or her overall status?
Well, they need to increase her oxygen.
We might need to see some orders for oxygen titration here. What else? If we possibly thought we had an infection based on our vital signs, what would we also want to ask for?
An antibiotic.
We might want to do something before we ask for an antibiotic right off the bat. What would
Blood
you?
work. Blood work.
Yep. So we're going to confirm that we have an infection. So the least invasive thing that we can do is just checking a full CBC. So we can look at our white blood cell count. If we had an elevated white blood cell count, then we could take it a step further and do some blood cultures to confirm the presence of an infection before we start antibiotics. So looking at her labs, we get that full CBC. How do we feel about our labs?
Her white blood cell count is a little elevated.
It's actually still in that normal range. So the normal range is 4 to 10,000, and she's at 8,500. So that's going to be reassuring for us.
Her red blood cell is a little low.
So that hemoglobin is right on the bottom of normal, but then our hematocrit has creeped just below normal. The reassuring part here is that our platelet count is normal, so we know we've got those clotting factors that we need. And a relatively low hemoglobin and hematocrit can somewhat be expected because we know she had that post-op bleeding as well as some blood loss in surgery. They shortchanged her a little bit when they gave her those packed red blood cells. They didn't quite replace everything that she lost. So that could be expected. Might be something we just keep an eye on, check again tomorrow, not necessarily jump on transfusing her again. We're going to skip her MAR. There's not much in there. Here we have our cast care teaching checklist. When do we want to start this with her and her parents?
Right away.
Yeah, we want to start this right away. We want to give them ample time to ask questions, to practice, to return demonstrate that teaching so that we can make sure that they understand what the expectation is when they go home. Is there anything else that you would want to see added to this checklist that might not be there?
To keep elevated.
Yeah, maybe keeping that leg elevated so that we don't end up with swelling. We promote blood flow.
How to wrap it when bathing or showering.
Yeah, how to protect it. Because she's got a non-waterproof cast, so she definitely can't get it wet. What else happens the longer you're in a cast?
Your skin gets irritated.
You get itchy. The first thing you want to do when it starts itching, what do you want to do?
Shove something in it to scratch it.
Yeah, you want to shove something down in that cast, and we definitely don't want her to do that because she can cause skin breakdown, and then it's in that warm, dark environment. So it's that perfect breeding ground for bacteria. So making sure we're not putting anything down in there. If we get itchy, maybe some signs to report if you see or when to return, warning signs to look out for. We already had compartment syndrome once, so making sure that doesn't happen again. Great job, guys. So lots of good information in here, especially if you are somebody that struggles with peds, with relating to those types of patients, because maybe you don't have a lot of kids in your life. You can utilize CJ Sim to really help you be able to tangibly grasp some of these kids. So we're going to go back to our Menti here, and we're going to switch gears to medications. So we are going to think about pharmacokinetics. So big word, that's just talking about how we process medications, so how it moves through our whole body. And we're going to compare and contrast a 6-month-old to a 3-year-old that are both getting acetaminophen. So as we think about that pharmacokinetics, the first thing that we have to do is absorb that medication. So which of those two patients is going to have the more mature GI system that's going to be more consistently able to absorb that medication?
The 3-year-old.
The 3-year-old.
Our 3-year-old. Our 6-month-old has a lot less surface area. So fewer opportunities to capture that medication. So once we absorb it, it has to be distributed through our body. Does anybody know if acetaminophen is transported in water or is it transported in fat in our body?
Isn't it in fat?
It's actually in water. So it gets attracted to water. Who has a higher body water percentage?
The 6-month-old.
Yep, the 6-month-old. They're at 70 to 80%, where that 3-year-old drops to 60 to 65. So acetaminophen likes water. So it's going to move, be distributed through the body a lot faster. Then we get to metabolism of that medication. So the actual breaking down of the acetaminophen. Where does that happen?
Liver.
That happens in our liver. So who's going to have the most mature liver?
A 3-year-old.
Our 3-year-old. So we reached that liver maturity at 2. So we're going to be able to consistently break that down. Our liver enzymes are a lot more active. So we're able to clear that medication out of our liver faster. Then once we've metabolized it, we have to get it out of our body. We have to excrete it. So how do we get rid of most of our medications?
Your kidneys.
Through our kidneys. We pee them out. So our 3-year-old, again, is going to have closer to adult levels. When it comes to their renal function, they have a higher filtration rate. So we can clear that acetaminophen more effectively. So we end up with a shorter half-life. We can have more predictable dosing intervals. Why do we care about all this? Why is it important, especially when we think about our 6-month-old and how delayed their response is?
We can't give more medication until the last dose is out of their system.
Yeah, what happens if we just keep stacking doses?
Toxic, they'll have a
Yeah.
reaction.
Yep, we'll reach toxic levels very quickly. And acetaminophen is one of those very common medications that causes toxicity. So as we're looking for signs of medication toxicity, what are some of those common ones that we see in pediatric patients? You guys can type them in or shout them out, either one.
Vomiting, nauseous, fever, chills.
Mm-hmm.
Are they like more lethargic?
They can be lethargic. What's the other way they can behave? The other extreme.
Oh, like really agitated, like irritated.
Yeah, irritable.
Hyperactive.
Yeah, hyperactive. What's the most common one on their skin?
A rash.
Rash.
Rash. Yep, rash. We can have some of those more adverse reactions like ototoxicity, where we actually cause damage to our ears. All of those are going to be those common signs of medication toxicity. So now we're going to move on to injections. Where are those 2 locations that we give medication or injections to school age and adolescent patients? Either shout them out or click on them.
On your thighs.
Yep, that outer thigh, that's our vastus lateralis. Nice big muscle group there. Where else?
The upper arm, like
Yep, our deltoid.
on the side of the arm.
Yep, our deltoid's our other one. If we have a large volume or something that would sting or burn on injection, which site would we use?
The thigh.
Yep, we're going to use that vastus lateralis. Our adolescents are probably going to prefer which site if we're thinking about privacy.
The arm.
Yeah. They're going to like their deltoid more. They don't want that leg exposed. So now we're going to shift into some procedural considerations here. We are getting ready to assist with a lumbar puncture in a 5-year-old. Which of the following positions would be most appropriate for this procedure? There are 2 of them.
Sitting upright in a chair.
There's a better one.
Side lying with knees drawn up to the chest.
That's one of them.
Sitting position with head. What's that, head and what?
Yep, head and shoulders rounded forward. So those are our 2 preferred positions. So ideally, our little ones, our infants, anybody that's not able to sit still for us, we're going to lay them on their side. We're going to curl them up into that ball. So that nice C shape. So that when we do that, we take their vertebrae that normally sit flat on top of each other. And as their back rounds, it opens up those vertebrae so that we can get in there with the needle very easily. For an older child that we trust to sit still, they can sit on the edge of the bed, their bottom all the way to the back of the bed, and then we'll just roll their head and their shoulders forward. We get that same opening of those vertebrae with that position, but we've got to be able to trust them to sit still and not to wiggle on us. Getting ready to start an IV in a 7-year-old. What's going to be our preferred site, our most appropriate site for them?
Their hand.
Powerful suggestions here. We actually would like the forearm. So coming back here in the forearm, we don't have to worry about them flexing their hand. They can still do everything that they want to without that IV getting in the way. Definitely don't want it in the foot because that's going to prevent them from walking around, having that good mobility. Also, I don't know a 7-year-old that has really veiny feet that it would be easy to get there. And then scalp IVs are going to be reserved for those infants as a last resort. So very traumatizing. If those come out, they bleed like you would not believe. So we save those as a last resort because it is traumatic to see your baby with a scalp IV. Here we notice our IV site on our 4-year-old has continuous fluids running and it has redness, warmth, and swelling at the site. What is that an indication of?
Phlebitis. Oh, yeah, phlebitis.
Infection.
So that redness, warmth, and swelling is going to be phlebitis. So that indicates that we've got irritation inside that vessel, either from the IV catheter, from the medications running through it, or it might be an early warning sign of an infection. Can be very, very painful too. If we had an infiltration, what would we see? Does anybody know?
Cool to touch and swelling.
Yep, we can still have the swelling. It'll be cold to the touch, can be tender as well. And then your IV probably won't infuse very well. So you might get an occlusion alarm on your IV pump. So with an infiltration, that IV fluid is leaking out into the tissue surrounding that vessel. So it's not contained in the vein anymore. So it's damaging all that tissue around. We're getting ready to give an IV medication. What action do we take before we give that medication?
All of them.
Flush the IV. Yeah, all.
Yep, we're going to do all of those things. We want to make sure that we have vital signs beforehand so we know any changes to our vitals that might have been caused by a reaction. We need that baseline assessment. We want to flush with normal saline so we make sure that our IV is working before we waste medication. We also want to keep it from interacting with our IV fluids where we could have a reaction between those medications. And then obviously we never want to give an expired medication. So we're going to check that expiration date. Here we have a 6-year-old's IV site and it's patent with no redness or swelling and good blood return. How do we document this? Good job, guys. Is this a normal or abnormal IV assessment?
Normal.
Yeah, this is a normal assessment. These are all things we want to see. So that's going to be what we're going to document. We're going to document exactly what we see, the fact that we have a normal working IV. So now we're going to look at a situation where we have a breakdown in the process. So if you've ever heard of like the Swiss cheese effect, um, this is a prime example here. So we're going to look at this busy urban hospital pediatric ward, and we have a 5-year-old girl named Chloe who comes in with a respiratory infection. So the attending orders a blood draw to check for any underlying issues. So they request a CBC and a specific viral panel. And we're going to read through this process and look for the issues and how it impacts the care that Chloe receives. So during the consent process, the nurse is pressed for time. She doesn't explain the need for the blood draw or the risks. So she just comes in with her supplies and starts in on that blood draw. Where's the problem there? So if I just come in and start poking your kid with not a word out of my mouth, where's the problem there?
You're not letting them know what you're doing. You also
Yeah.
don't know if you have like the right patient.
Yeah, absolutely. How does that make you feel as either the patient or the parent?
Very confused and startled.
Yeah, absolutely. Big timeout. Like, whoa, what is happening here? Take a minute. So then we are actually moving through the blood draw procedure, and we get a phone call. So we hastily collect the specimen, and we don't properly position Chloe's arm. So we have to poke her multiple times, and we end up with a poor quality specimen. Lots of things went wrong here. Where do we even start? What do you guys think? Where did we first go wrong?
It sounds like she was rushing.
Mm-hmm. Yeah, we were rushing. We didn't follow our procedure appropriately. Maybe we got distracted with that phone call. What should we have done in this situation?
Not answer the phone.
Yeah, not answer the phone. Focused on the patient in front of us. Say that was a really important phone call. Like we had abnormal lab results on another patient and we were waiting for that physician to call us. What could we have done?
Excused yourself out of the room.
Yeah, stop.
Yeah. What could we have done so we could do both things? Or so that both things would get accomplished? Are you the only person on the unit that can draw blood?
Ask another nurse to assess and draw the blood.
Yeah, we could ask for help. Use our resources here. So we didn't position Chloe's arm well. We had to poke multiple times. Again, if we were rushing and we were distracted, maybe it was better for another nurse to do that procedure for us, or maybe we just aren't great at blood draws. So it might have been nice to call in some reinforcement and utilize somebody that maybe was more successful at them. So not only do we have a poor quality specimen, but now we stick a temporary sticker on it and we throw it in a non-insulated container where we end up with temperature fluctuations. What are the two problems there?
The label could fall off.
Mm-hmm. What happens if we have an unlabeled specimen?
It gets thrown out.
Gets thrown out? What happens if we like just left it on the desk?
Contamination.
We don't know who it belongs to.
Right, they're not gonna do nothing with it.
Can get mixed up with somebody. If it makes it to lab, they're just going to throw it in the garbage. They're not going to think anything of it. So again, we've got issues there. Why would temperature fluctuations be a problem with a blood draw?
The blood will clot.
Could potentially clot. What else can happen? What happens to your results?
It can give you abnormal results.
Yeah, we can end up with abnormal results. So poor lab is unaware of everything going on. So they just process the sample. When the results come back abnormal, they call the pediatrician with those abnormal labs and they are very alarmed and immediately call for further testing. So because we had a horrible quality specimen that wasn't transported correctly, we have all these abnormal lab results. What happens to poor Chloe?
She gets poked again.
She gets poked again for sure.
She don't get the proper diagnosis either.
Yeah, we still don't know what's going on with her. Do you think we're going to be successful with collecting more labs on Chloe?
Probably not, especially not with that same nurse.
No, we have been traumatized by this situation. So the likelihood of us getting more labs is going to be very slim here. So not only that, but we've got no closer to a diagnosis. We may have started other treatments that weren't necessary because of misinformation. How does this impact the staff on the unit?
It kind of makes them all seem careless.
Yep. What else is going to happen because we had a process error?
taking more time away from the staff, which taking more time away from the other patients.
Yep, we are taking time away from everybody else with having to draw all these extra labs. When management hears that there was an error, what are they going to bring in? What are they going to make the staff do to prevent that from happening again?
Train.
Yep, we're going to have to retrain the entire staff. So when we have those breakdowns in our procedure, unfortunately, we end up having to go through additional education for the entire staff, on top of all the trauma that we've put our patient through. So it affects every single person involved in the situation there. So looking at some more procedures here, we're teaching parents of a child with a newly placed G-tube. Which statement indicates a need for further understanding? You guys got it. We've got to use whatever feeding is ordered, so that we know that we're getting the proper nutrition into our child. And we want to make sure that what we're using isn't going to clog that G tube or cause breakdown of the tube itself. So we have to make sure that we're following our prescription order here. We're assessing a patient receiving oxygen via nasal cannula. Which finding would indicate that the patient is receiving adequate oxygenation? So how do we know that our treatment is effective?
Increased respiratory rate.
There we go. We want that oxygen saturation to go above 90 for us. Our tachypnea, our cyanosis, our accessory muscle use, those are all going to be signs of respiratory distress. So indications for the use of oxygen there. Getting ready to suction a 3-year-old child with a tracheostomy. What is our priority nursing action before suctioning? How do we prevent those complications?
Is it hyperoxygenate the child?
Yep. We want to give them that extra oxygen boost beforehand. So we know that when we're suctioning, we're cutting off that air supply. So we want to boost their oxygen up so that we can still have that fluctuation, that drop, without causing them to go too low. Okay, guys, last one. We are performing tracheostomy care for a child. Which intervention is most important to include in the care plan? So think about why you're doing tracheostomy care. And if you eliminated one thing, what would cause harm to your patient? What are we doing when we're doing tracheostomy care?
You can use cotton swabs to clean around the stoma.
Yeah, we've got to provide that cleaning. So that's the whole point of it. We're cleaning that site so that it stays free from infection. We could change our trach ties as often as we wanted. We can look at the stoma all day long, but if we don't actually do that active cleaning, that's what's going to cause harm to our patients. And we're only going to suction them when needed, so not routinely. Okay, guys, do we have questions on anything that we covered in class so far today? Okay, we'll go ahead and dive into some Kahoots here to finish up our night. Okay, we will go ahead and start with who we have. I did drop the pin in the chat if you want to join later. So adolescents are in that last stage of Erickson's theory as it pertains to pediatrics. So they are in that identity versus role diffusion or role confusion. Either one means the same thing there. But their body image helps make up who they are as an individual. So with toddlers, that thing that promotes security is that ritualism. So it's following that normal everyday routine, doing things in the same way, the same order every single time. Uh, they always want to do it their way. That gives them that sense of security and understanding what comes next and what those expectations are. So Kohlberg is our understanding of right and wrong, and that conventional stage is that middle stage, which pertains to our school kids, and they follow the rules because it's the right thing to do. So they're all about following the rules so that people have a good opinion of them. So for our young patients, we're going to be pulling that ear up and back to get that ear canal straightened for us. The most accurate way of determining a correct medication dose for a child is going to be that body surface area. So that BSA is that big long equation that goes under the square root sign. That's going to be our most accurate way. So if we have a medication that we know is extremely toxic, we're going to go ahead and do that complex formula to make sure that we narrow in on that appropriate dosing based on their weight. When we are administering medications to children, obviously our preschoolers are going to want either a liquid medication or a chewable medication. Our toddlers, because they are trying to exercise that autonomy and control, are going to be very resistant to complying with medications. We want to plan additional time because we know we're going to meet some resistance. There's going to be some give and take that has to happen there. And if we give them choices afterwards, it's going to encourage that cooperation. So, hey, I have your medicine here. Do you want orange juice or apple juice afterwards? Or which color popsicle would you like after your medication? Allowing them that choice gives them a little bit of control and gives them a reward for doing what it is that you're asking of them. The most important reason that we have to have an accurate weight on a child is to make sure that we're dosing their medication correctly. So the last stage of Piaget's theory for our adolescents, where we've got that increased moral reasoning. So this is going to be formal operations with that fancy adult level thinking. So under 5, we're going to use that apical pulse for assessment. Why do we have to use that over our radial pulse? Why do we make you listen for a full minute?
Is it because it's more accurate?
Yeah, it's more accurate. We get lots of fluctuations in those pediatric heart rates. Also, our kids under 5 don't have the best perfusion. So you may not capture every single beat if you are relying on that really distal site. So bottle popping is a huge no-no. Do not allow it. I don't care who you see doing it. It is a huge safety risk because it does increase that risk for choking. So by leaving that bottle shoved up in that baby's face, there's no way for them to get away from that if they get too much in their mouth. So it really increases that risk of choking. So if we are doing a scalp IV on an infant, we want to make sure their entire body is secure. So we're going to use that mummy restraint. So we've got them nice and secure so they can't smack at us, they can't kick us, and hopefully they're not wiggling their heads around too much for us. So our tetracyclines cause discoloration to our teeth. So we try and avoid them in kids under 8. If we have to use them, then we have them take it with a straw, rinse their mouth out afterwards. If you struggle remembering that, tetracyclines has 2 T's in it for terrible teeth. So we should start using a spoon or fork around 2. We should be pretty skilled at it by the time we're 3. So that 2.5 to 3 year window is when we're pretty independent with it. Nice job. So we don't want to compare kids to each other. We want to give them that choice afterwards for doing that required behavior. So it's time for your medicine. Would you like water or juice after it? Gives them that reward for complying, gives them that opportunity to make a choice. So, a fever after an immunization is part of that normal immune response. So, this is to be expected. We want that body to learn how to fight this off. So, one of the ways that we can do that is by increasing our body temperature. Hourly IV assessments are required for pediatric patients. So with our school age kids, their sexual energy is at rest. So that's that latency phase. So their priorities are learning new information and forming those friendships. So ideally for a toddler, you're going to have the best luck with them if they are in a crib where they can't get away from you. Um, Sitting in a high chair, elevated chair, not an actual like booster seat high chair. We've got that risk of tipping over when we try and wiggle away from our nurse trying to give us medicine. With the crib, we've got the added benefit of them being able to lay down and you have something to kind of hold their head against if you need to restrain them. Um, and we always feel like it's comforting to have them sitting in our lap, but for your own good, I don't recommend it so that they don't spit their medicine all over you. So after we give nose drops, we want to keep that infant with their head flat for at least 30 seconds to a minute so we can allow that medication to fully work its way down the sinuses. We do a lumbar puncture to look for spinal fluid. So toddlers are most known for their parallel play, that playing in close proximity to somebody, but still doing our own thing. Okay, so we got sick because we went swimming in the rain. Is this a cause and effect that makes sense, or is this something that doesn't go together?
That wouldn't be pre-operational.
Nope. So if we get sick because we're out in the rain with little clothes on and we're soaking wet, say it's kind of chilly that day, is that a logical reason for getting sick? If we compare that with I got sick because I hit my brother, which one is logical?
The rain.
Yeah, so that's why it's a concrete operations. If the two have nothing to do with each other, like we know that we don't get sick because we did something bad. That's what makes it that pre-operational stage that we see with our preschoolers. Those are tricky. So look at it as, okay, is this logical? If it is a logical way of thinking, then we move it to concrete. If it doesn't make sense to you in your brain, like that's not why we get sick or that's not why we're in the hospital, then it would be that pre-operational stage. Those are tricky ones. I'm glad we got to that one. Um, let's go ahead and stop there. We'll see who our winner is. Looks like KJ is our winner today. Great job, guys. And we will take a peek at what is coming up. So if you haven't turned in your week 2 discussion, you can still turn it in for partial credit. This week we just have our NCLEX questions that are due, which are a great study tool for you as we get ready for our exam. So just make sure that you're referencing that screenshot in your announcements to make sure that you got it set up correctly and you have all 50 questions in the right areas. And then make sure you're submitting that PDF printout that has all of the question categories, how many you tried, how many you got right, how many you missed. That is the report that we are looking for. Next week, we have our discussion 3 that will be due. And obviously, our exam is next week. With your discussion 3 post, make sure that initial post is getting in by Wednesday. We've been pretty lenient with that with all the class changes that have been going on. But starting with that discussion 3 post, we're going to start marking off if that initial post is not in by Wednesday. So make sure you get that initial one in by Wednesday night. Your peer responses can wait until Sunday. And remember, you only have to do 2 peer responses. You guys still have one more opportunity for an exam review in person on Sunday, the 26th at 4 p.m. Eastern Time. Professor Luminoso will be doing the final exam review before we start exams. So remember, you just have to open your calendar and then click on that exam review and you get a direct link to her Zoom. And you also have that ID listed there for you if the link wouldn't work for some reason. So we will see her on Sunday at 4 for that last exam review. You guys do have the recordings posted from Dr. Becker and myself to be able to watch and review. Best thing for you to do is look at those study guides and look at the review sessions. So look at that review PowerPoint. You guys also got a worksheet for this exam. This is the only exam that you'll actually get a worksheet for because it is kind of tricky to figure out what we're going to ask about these theorists. The exam is heavily weighted on theorists and developmental milestones and then nutrition. Those are like the 3 main categories that we cover. What questions do you guys have about what's coming up over the next week or so? Any questions? Okay. You